And the talk I chose for myself for this oration was why I do what I do. And it's just not a clever play of words. I really wanted to express myself through a forum, and I thought this is a great opportunity to express myself. It has been mostly seen in the last decade or so that instead of evidence-based medicine, there has been a replacement by many other strategies like evidence-based medicine, evidence-based medicine. Everybody does, so I will do it based medicine, and Mandar calls it FOMO-based medicine. In my hand, it works evidence-based medicine, eloquence-based medicine, conference-based medicine, clairvoyance-based medicines, belief-based medicine, I think, therefore I do, and lastly, trend-based medicine. And I would implore you all to reconsider any kinds of practices that you do and recalibrate yourself to bringing back to evidence-based medicine, not because I am not in favor of innovation or experiment, just because that there must be a strict set of criteria if you want to deviate from evidence-based medicine. So there is a huge body of experts which meet to lay down the guidelines, and they come from a large body of evidence of literature. Lots of hours go into reading them and making guidelines. And if the guidelines are there and if we are not adhering to it, we are probably doing disservice to all the people who are laying down the guidelines. Now imagine if you had a drug in the market which came without any trials, would you take it? But if a surgical procedure came to the market without a trial, you would take it. Why is there a difference? Why are surgeons so different from physicians? So I'm going to just talk about, on a personal journey, why I do what I do to prove something, at least, that we should stick mostly to evidence-based medicine. I've divided into 5 parts: groin hernia, primary ventral hernia, incisional hernia, lateral hernias, and recurrent or giant hernias or loss of domain hernias. Why these 5? Because all these 5 are different diseases, just like a malaria is not a tuberculosis, just like HIV is not a typhoid. Similarly, these are all different. The primary ventral hernia has nothing to do with incisional hernia. Loss of domain hernia is very different from an incisional hernia. So these 5 hernias, let's take the first one, groin hernia. Now I'm going to probably stir a lot of your nests when I say that there is no evidence to prove that a minimal access surgery for groin hernia is any better than a Liechtenstein repair. I know many of you will be uncomfortable saying this, but there is no hard level 1 evidence to show. Therefore, if somebody is doing a Liechtenstein for a primary unilateral hernia, like in the NHS in UK, you would still do it. Then, what does it tell you? It tells us that if somebody is doing a Liechtenstein repair for unilateral hernia, it's fine. If somebody is doing MIS, it's fine. Somebody is doing robotic, it's fine. But they should not consider themselves either superior or inferior to what they're doing, what their colleagues are doing. Now, this is an algorithm that I follow based on what was published and based on what evidence I showed you. I do about 10 to 20% of my practice of Liechtenstein repair. And that comes from the fact that I want to play it very, very safe, especially for the elderly people. And this is coming from a unit of mine which is dedicated MIS unit. But we listen to our anesthetists and we listen to our patients. If there's a thin elderly gentleman, what advantage can I give this man with an MIS repair? So in a female patient, there's a distinct advantage based on the literature. It has to be either a laparoscopic endoscopic repair or an open pre-peritoneal repair, because you don't want to miss the atypical hernias. But in a male patient, if it's a femoral hernia, again, just like a female hernia, a femoral hernia in male should be tackled by either a laparoscopic endoscopic repair or an open pre-peritoneal. But if it is an inguinal hernia, then you have the choice of watchful waiting. You may not do anything on a bulge patient, elderly patient with a direct hernia, broad-based. But there's a lot of practice where we do repair these patients. This is unnecessary. But there's no evidence. And second, If some patient is averse to a mesh, you could do a suture repair, a shoulders repair, which is equally effective, right? That's the patient's wish. And if you say you deny it, you're denying evidence. Similarly, if you do mesh repair, you could do Liechtenstein, you could do laparoscopic or endoscopic repair, right? Now, when we talk about evidence, there's no denying that if somebody's got a bilateral groin, recurrent groin, or a patient of groin hernia with obesity, then laparoscopy or endoscopy will be superior. So there is evidence. So if you had these kind of patients, there is absolute evidence. If you had a patient with a large hernia, irreducible groin hernia, sliding hernia, suspected strangulation, yes, then you have to decide between TAPP, TEP, ETEP. I have done TEP all my life and then ETEP in the last 8 years, and now I am doing TAPP mostly. TAPP surgeons have the last laugh. Why? A, I am doing more robotically and they are all TAPP. Yeah. 2, I have realized that I have at least, I have 8 to 10 hours of working time and I have to finish a lot of things. I need to do it quickly. Time is of essence. I cannot take a chance of having injuries or anything to which impedes my working time. So I have realized in my own audit that if I do a TAPP, I have the maximum control on the patient's disease. Right? Now, primary ventral hernia. Moving on to the next one, umbilical epigastric. A primary ventral hernia, if you see a small hernia, umbilical hernia like this, open sublay repair, open preperitoneal repair remains the guideline. But if somebody is an MIS, you want to do IPOM plus, fine. You want to do TAPP, fine. You want to do robotic TAPP, fine. You want to do TARM, ETAP, fine. But if you look at TARM and ETAP, they cut the PRS of the patient. For a small hernia like this, that seems like an overkill. So even if you do not give me evidence, I would say, coming from just basic science, it doesn't appeal. I have done it, but it doesn't appeal to me anymore. I would rather like to use another evidence-based, another common sense, another scientific approach for doing an umbilical hernia. But for learning, yes. For doing practice, no. Incisional hernia. We know from the systematic review way back 12 years back that the recurrence was highest for onlay. So if you're doing onlay, don't do onlay for incisional hernia. They are the toughest patients. Your first operation is your best chance. Don't do an onlay. Do a retrorectus instead. Just do retrorectus if you are comfortable with it. So that gives you the least recurrence. Also, a systematic review showed seromas are least likely in a retrorectus repair. Even if there was contamination, well, in contamination, don't do any mesh repair. But if you had to, choose a sublay repair. And the other thing that you must pay attention to is the mesh defect area ratio. Today you saw surgeries where all operators were concerned, how much of overlap would I do? And that's important. If you had a small defect, you need a smaller mesh area. So this was the first paper way back in 2016 which talked about if the defect is of a particular area, let's say it's a 4 centimeter by 4 centimeter, that's 16 centimeters. Then if you do 16 times that mesh area, that area of the defect as a mesh, then your recurrence rate is close to 0%. But if you go close to 10, it will rise to 10 to 20%. So what you want to do is, you know that a IPOM mesh, coated mesh, typically is 20 by 15, that's 300 centimeters square. So anything which is a 5 by 5 centimeter defect, beyond that, you're not having an adequate mesh defect area ratio, right? So don't do an IPOM plus for those patients, unless there are some caveats. And if you have a non-midline hernia, a right iliac fossa hernia, suprapubic hernia, subxiphoid hernia, use extraperitoneal repairs because you can't do a IPOM and tack it to the pericardium, right? And you can't tack it to the bladder. You can't tack it to vital organs and the nerves in the right iliac fossa. So extraperitoneal repairs. So we devised, based on those evidence in the literature, our own approach in 2017 and published it, where we use IPOM and IPOM plus in smaller defects. But the defect size goes bigger. The mesh defect area ratio cannot be met with a 20-15 centimeter mesh, coated mesh, which we are happy to handle. We go to doing Reeves stopa. We can do it either endoscopically, or we can add TAR to it if it's a complex hernia like a recurrent hernia, like multiple defect hernia, like a diastasis. Okay, then we have to do TARs. So this is a patient, recurrent hernia, And because you've already seen a ETAP reef stopper today, we are in the left retroactive space. I'm at 6x. I don't operate this fast. So it's a very, very fast video, because you already know that the left retroactive space is being developed. We are going right to the bottom. Then we are applying more trocars and we are doing a crossover. Why I want to do it so fast and I still want to show you this video is because to show that depending on what hernia we have, we are tailoring our case. Now this patient, when you will see, we have crossed over from the top, and when you go down, this is a long midline laparotomy. And if I did an IPOM for this patient, I wouldn't be able to close the hole at the top. I won't be able to put in a mesh 30 centimeters by 15 centimeters coated mesh. I won't be able to. Now that's the first defect at M2 level. Then you go down, you see sutures there. And this has been already repaired with a mesh, okay? That's the second gap that you're going to see. Then you'll see a third gap, and you can see the mesh also out there. Then we'll see a fourth gap. So if I were to do IPOM plus for this patient, that wouldn't be a good choice. This patient with incisional hernia, recurrent incisional hernia, not incisional hernia, a recurrent hernia needs the best. So now if I do a TAR here, what will I do? I'm doing the Bogro space. I'm slowing it down a little bit now to show you that's the Bogro space. So first, when we do the TAR, we do the right side TAR first because you're on the left side, so it's easy to start. And that's the Bogro space being developed. Then take a gauge piece and we look at the arcuate line well. And with the gauge piece, we first do the lateral peritoneal space. We create that so that doing the TAR becomes easy. Now, why am I saying all of this? I'm saying this because I want to tell you why I do what I do. Here, I am trying to tell you why I do a bottoms-up TAR. Why don't I start with a top-down TAR? In this patient, it's M2, M3, M4, W2 hernia. Because it's easier. Because I am used to doing a TEP so often for the groin, I know I can do the Bogro space well. I know I can create the lateral space well. And therefore, starting from there makes sense to me. It is easier. So why I do what I do is here I do bottoms up TAR. You can see the small hole there. And I've stopped it there so that I can show the neurovascular bundle there. Don't miss the neurovascular bundle. You're doing everything medial to neurovascular bundle. Remember, ETAP techniques are taxing. You need to be mentored first. Don't do it unless you've been mentored. You have done many cases with somebody, and then when you do it yourself, have somebody by your side. Now I'm going up, and every time my head is on the neurovascular bundle. Now we're starting from top to bottom. Again, if you see, I am doing the Madrid approach, which means I'm not going right up. I am 5 centimeters below the xiphoid, and I'm going more transverse. I've cut the posterior lamella ventral oblique, and now the TA muscle, and I'm going to go down and join the two. So the TAR here again is something that needs to be learned, and this is like a bottoms up and top down approach. And I'm just going to forward this a little bit for the sake of time. So now you see it makes it easy. If you're coming from the top, from the bottom, it makes it easy. So there's something we learned a hard way up of coning it down, coning it to the part where it becomes easy. Otherwise you keep making a lot of holes. So that finishes the TAR. And then of course we suture and we put in the mesh, and you can see the TA muscle at the top. So when you see you have created such a big space, now if you put in a large mesh, the chances of recurrence are low, right? Provided you can close the posterior and the anterior well. So what a huge space you can create when you do a TAR. And in these recurrent hernias, it gives you a lot of confidence that this patient is not going to come back for another surgery. So again, we close it horizontally, which we published, that you must close the PRS, and then you close the anterior. And the anterior closure is very important. It must be done well. And you must have good practice for doing it. And ultimately, we will put in a huge mesh there from the one end of the axial line to another end of the axial line. We do it in a double cigar fashion. So that finishes this. Now, for a third component, subcostal hernia. Many of you may have seen after an open cholecystectomy a big subcostal hernia. How do you manage it? You know, when I take a poll, most people give me an answer which is very vague. And the reason is because we don't have a algorithm in our head. We have not figured out what to do. And there's nothing shameful about it because I was there in the same place. So we did a Delphi consensus for global experts. And would you believe it, in the global expert with the Delphi consensus, when we conducted the study, we found that there was no consensus as to what to do for a subcostal hernia. And therefore, I read all the repairs and I incorporated Edinburgh repair in my practice, which is basically a concept of using the peritoneal flap plus staying in the plane which is simple, retrorectus and between external oblique and internal oblique, not worried about the TAR plane. Why? Because the subcostal incision has already divided the neurovascular bundle. What is the advantage of staying in that plane where I'm going to create more holes and leading me to no advantage? Because I'm not going to preserve any neurovascular bundles. They've already been cut. Lastly, when we get very giant hernias, the final chapter, something like this, with a loss of domain, I can't put them all back in without doing something. And at the same time, our IEHS guidelines tell us linea alba should be reconstructed. So we have a bigger problem, but we have a bigger target also of closing the linea alba. How do you do the reconstruction? They say component separation. And therefore, we use component separation, both anterior and posterior component. And what we found in reality is, which was published in Cleveland Clinic, despite the component separation technique, we are unable to close the defect in a large number of patients. Honestly, a posterior component separation technique does not give you a good ARS, anterior rectus sheath release, medialization. We still are left with a bridging repair. And therefore, we have composite recurrence as much as 50% published by Cleveland Clinic. So what do? These are your alternatives. Peritoneal flap, already spoken by Vikas Singhal, so I'll not go so much into it. Fascial traction device, I'll touch it, and botulinum toxin. So this was the paper that was referred to earlier. But I'll just show you a case. This is a patient where a Hartmann's has gone haywire. There's necrotizing fasciitis. The entire area is gone. There's no abdominal wall, just skin and hernia sac. What do? We are going to use the sac, right? We are going to take away the skin from there. We have the peritoneal, the hernia sac now, and we do a TAR on the left side. We put in a huge mesh, and we close the gap using the hernia sac. But still, good result. The hernia sac is good. Again, this patient, we use a fascial traction device. After this gap was there in a male patient, when we went in, we found that we are not going to oppose it. So we brought up our fascial traction device, applied it for 30 minutes, and we could suture it easily. So this prevents doing TAR in complex cases and getting your fascial traction, gives you a position. And finally, when you get these patients, you will get a lot of patients, but one of the problem would be half of your patients with incisional hernias will be obese. You do have an algorithm in your head, a clinical pathway in your head to deal with them. Are you going to operate all obese patients with ventral hernias? No. If you see ventral hernias, they come in different shapes and sizes. What are you going to do? So what we saw in the evidence was that the patients with severe obesity and large complex hernias which are not amenable to laparoscopic repair, a stage repair should be considered. That comes from a large body of evidence. So what we do is we publish a paper where if we get favorable obesity with favorable hernia, we'll do an IPOM plus or endoscopic reefs, but no problem. If we have a favorable obesity with unfavorable large hernia, but the obesity BMI is 30 to 40, there's no diabetes, we'll still go ahead and do an AWR procedure like a posterior component. This comes from the Charles Butler group large publication, so we follow that. Third is, if the obesity is unfavorable, like that's a diabetic, BMI more than 40 patient, but still the hernia is small, we'll do an IPOM plus and we'll do more fixation, and we'll do a medical weight loss for that patient. And finally, if we have a fourth picture, an unfavorable hernia, obviously a large hernia, and a BMI more than 40, diabetic patient, what are we going to do? Bariatric surgery first, and then hernia. I'll show you. This is the patient we're talking about. We do a sleeve gastrectomy, and once the sleeve gastrectomy is done, patient's lost a lot of weight. After about 9 months, you take this patient, you do a TAR plus, patient looks like this. So before and after, that's what happens. You can still do good surgery if you can incorporate bariatric surgery in your practice. Summary. Am I saying the evidence is the only way of practicing? The other ways are not good? No, not at all. I think intuitive knowledge is good. I think common sense is good. I think scientific, rational thinking is good. That practice is good. But if we talk about innovations and experiments, without innovations and experiments, we cannot move forward. Science cannot evolve. We would not have had a TAR, fascial traction, botulinum toxin, if had it not been for innovation. So we need to innovate. But who should do it and how should it be done? A, people who are into this for a long time, they are probably the better people of doing it. First we get the basics right, and then we start evolving or trying something new. And how should it be done? It should be done as a controlled trial, just like you would do a drug. Put the drug under evaluation. Put your new procedure under evaluation. Collect the data. So I, Yusuf and Vikas, when we thought we'll do a peritoneal flap, we collected all data on an Excel sheet. We watched these patients for 2 years. We looked at all the data in the same way. We did the same operation. And after that, when we analyzed the data, we found, yes, it works. So, yes, in God we believe, but the rest must bring evidence. But if you don't want to bring evidence, if you can't bring evidence, what you can do is collect evidence, evaluate your evidence, and publish your evidence. Thank you very much.